Hello everyone, so we continue with our discussion to master the gastroenterology system cases. So you get a patient who's 62-year-old, came in, had diverticulitis. You gave him, if he wasn't with comorbidities, you give him oral antibiotics, send him home. Or if he with comorbidities in the inpatient setting, you can do IV Zosyn or oral Levaquin, Flagyl, or IV, same. You can do that. If it's more sick, you can do IVs too. And then so they tell you, okay, what to do after that, after he gets better. Then you do arrange outpatient colonoscopy. Okay, that's one thing that you want to look for. Okay, now, patient come in, 68-year-old, took azithromycin Z-Pack for some reason, pneumonia or whatever, pneumonia for, and then developed like yellow skin, elevated high LFTs, and they tell you what's best next step, change antibiotics. Okay, why? Because there are some antibiotics can causes jaundice. Okay, and usually when there is high LFT, there is something called GGTs. So this is going to make us talk about LFTs. So or alkaline phosphatase, whenever there is elevated alkaline phosphatase, first you want to rule out physiologic causes, like is there a pregnancy or postprandial. Okay, after you rule that out, then you check the GGT. If the GGT is normal, it's likely bone in origin, it's coming from the bone. If the GGT elevated, then likely biliary in origin. So what you do, right upper quadrant ultrasound and antimitochondrial antibody. Okay, if the ultrasound had dilated bile duct, then you do ERCP, MRCP. If the antimitochondrial antibody positive with normal ultrasound or antimitochondrial negative with abnormal hepatic parenchyma on ultrasound, then you do liver biopsy. Okay. If both ultrasound and antimitochondrial antibody normal, then you assess the degree of elevation. If it's more than 50% elevation from normal, then you do liver biopsy or ERCP or MRCP to look what's going on. If it's not too high, just a little bit, then just observe, nothing to worry about. Okay, now this patient, 33-year-old woman, have gastric bypass. Okay, and then develop abdominal pain, nausea, diarrhea, dizziness, 15 minutes after food. What's best next step? What do? You do what's the diagnosis? I mean, that's what they tell you. Why is that? This is called dumping syndrome. Okay. So dumping syndrome has two types, like the two manifestations, early and late. Okay, this is like everything. Lyme has early, late. Syphilis have early, late. Celiac, like a lot of diseases, have early and late manifestations. So dumping syndrome is like not any difference. Like the early usually have abdominal pain, diarrhea, nausea, hypertension, tachycardia, 15 to 30 minutes after meal. Okay. The reason for that, it's rapid emptying of hypertonic gastric content. Okay. Late, usually you have dizziness, confusion, fatigue, diaphoresis, syncope, 2 to 3 hours after meal. This is usually due to reactive hypoglycemia. How do you treat it? You do a small, frequent meal for both, and then replace simple sugar with complex carbohydrate, and then you incorporate high fiber and protein-rich food. Okay. Okay, now you have a patient who's 61, comes in with epigastric pain. So what do you do? Whenever you see 61 with epigastric pain, just do EGD. Okay, epigastric pain relieved by eating. Why? Because this is dyspepsia. How do you work up dyspepsia? Dyspepsia, first you eliminate aggravating factors like alcohol and NSAID. Stop that. If there is a typical GERD symptoms like heartburn, regurgitation, then this is a heartburn, just give PPI and follow up as an outpatient. If there is no GERD symptom, just like dyspepsia, just discomfort, and then the patient is above 60 years old, then you just do endoscopy. Okay. If younger than 60-year-old, just do H. pylori testing. If it's positive, you treat H. pylori. If it's negative, just do try PPI. See if it helps. Okay. If it doesn't, then you can do EGD or so. So now there's another case, is 35. Same thing, early satiety, epigastric pain for 6 months. Just like we discussed, we do here what's best next step. H. pylori, stool antigen. Okay. This is gonna give us the idea, because if it was, if just the age was 61, then you do endoscopy. Okay. Same thing for this patient. Same thing for this patient. The patient, this one, they try to trick you. Like somebody, 42 woman, comes in with epigastric pain. So you do ultrasound, right? Ultrasound shows 3-4 millimeter gallstone. You tell your best next step. What do? You take the gallbladder out. You do H. pylori testing. This one again, H. pylori test. Why? Because this can coincide with dyspepsia, and this is small stone may not be the reason for causing this dyspepsia. You know. So now you have this 75-year-old man came in with weight loss, poor appetite. There's halitosis and decaying molars and crackles in the right lung. Right lung crackles, coughing. So this guy had aspiration pneumonia from halitosis. What do you do? What do you think? What's best next step? You do barium. Swallow, modified barium swallow. Why is that? Because this is suspecting Zenger diverticulum, or it could be like one form of oropharyngeal dysphagia. Okay. So how do you know what are the types of oropharyngeal dysphagia? There are two types. There is one neuromuscular and there is mechanical. What does this patient have? This patient have mechanical, like Zenger diverticulum. Others mechanicals, like esophageal webs, tumors. Cervical osteophyte can cause that too. What is the neuromuscular causes for oropharyngeal dysphagia? Could be stroke, Parkinson, dementia, myasthenia gravis, tardive dyskinesia, amyotrophic lateral sclerosis. Okay. Now this patient is 48. Okay, came in with food stuck in chest. So you do EGD, shows ring. They tell you what's complications of this patient. Complications, you can have recurrent rings. Okay. And how do you manage the rings, by the way? The dilation. So this guy already got dilation, and then they tell you what's the complication. This could happen again as expected. This is Chasky's ring. So you treat it with dilation and acid suppression, and may recur as well. So you wanna keep an eye on it. Alright, this case is interesting. They see 63-year-old comes in with sudden epigastric pain, vomiting, decreased breath sounds, fever, low blood pressure, high heart rate. So you do chest X-ray. Chest X-ray showing pneumomediastinum with moderate left pleural effusion. That's very concerning, right? So what do you think is going on? Sudden epigastric pain, very severe chest pain, pneumomediastinum. This is always you to suspect of rupture, esophageal rupture. So what you would do, you would do contrast esophagography. This is very high risk for complications and cause a lot of issues. So how do you manage esophageal perforation? First you do chest X-ray. If there is mediastinal or free peritoneal air, then you do chest CT or esophagogram. If there is a free perforation, then you consult surgery immediately. That's the first line. And then they may do endoscopic stent placement in select cases. If there is contained perforation, you do NG tube, NG suction, IV broad spectrum antibiotic, total parenteral nutrition. And if there is abscess or effusion, then you need to drain it. Okay, that's a very important question. Another way they bring this question is that somebody, they give you, okay, 80-year-old came in with chest pressure, dyspnea, and then there's scattered bronchi, dullness to percussion. So you do chest X-ray, you see left pleural effusion and retrocardiac air shadow. This is all, and they tell you what's best next step. This is also concerning for esophageal perforation, so you need to do contrast esophagogram. Okay, this patient you will need to do contrast esophagogram for retro cardiac. This is suspecting esophageal rupture. It can happen: vomiting, chest pain, subcutaneous emphysema can cause that. Okay. Another important clue is a rapid development of pleural effusion. This can develop quickly with esophageal rupture. Okay. Alright, so let's review. We talked about esophageal rupture, and you do contrast esophagogram. We talked about dilation and recurrent rings for esophageal ring. We talked about barium swallow for Zenker diverticulum. H. pylori, dyspepsia, we discussed that. Till antigen. Then when you do EGD, we talked about dumping syndrome. We talked about changing antibiotic for jaundice and outpatient colonoscopy after diverticulitis. That concludes our discussion for this section. Thank you for listening.